of Nephrology since 1993. He did his MD Medicine from Delhi University in 1979. Widely traveled and recipient of many national awards, Professor Sharma has more than 250 publications to his credit. His special areas of interest are maintenance hemodialysis and renal transplantation. Sir, please.
Good afternoon, ladies and gentlemen. I'm going to present this very difficult scenario of renal support in patients with septic shock. There's a term which we are familiar, acute renal failure, which is very old terminology, and now in 2007 it was proposed that acute renal failure should be replaced with acute kidney injury. And then there were groups who were meeting and trying to look at a standardized nomenclature, definition, and staging of acute kidney injury. What I want to emphasize that you can have acute kidney injury when your serum creatinine may still look to be either in the normal range or very mildly elevated. And these are the two groups, the Acute Dialysis Quality Initiative Group and the Acute Kidney Injury Network, which started working in 2000, who have been responsible of making standardized terms in terms of acute kidney injury. And Ronco, who is an Italian nephrologist, he has been in the forefront of this acute kidney injury network, and the other person is Mehta, who is from United States, a nephrologist. And when we talk about acute kidney injury or acute renal failure in relation to patients who are in intensive care or patients with septic shock, the criteria which Acute Dialysis Quality Initiative way back in 2004 proposed is the rifle criteria, where essentially the risk of kidney injury going on to the actual injury failure as demonstrated with biochemical disturbances, loss of renal function, and then an advanced irreversible end-stage renal failure all could occur. So acute kidney injury is really a very complex situation where an injury which continues can ultimately result in reversible renal failure. And what is interesting to note that though there are a lot of randomized studies how to protect kidneys, but the most important thing which has come out is the very simplest thing, is that the most effective form of renal protection is volume, which is in contrary to the lungs, where you want to keep the lungs dry, but the kidneys, if you want to save them, then they need a lot of volume protection. This is the acute kidney injury network diagnostic criteria. I just want you to note, which is relevant in relation to septic shock, that you we'll have patients who will fall into the category of acute kidney injury, where the urine output has just declined in last over 6 hours. So even if there's a reduction of urine output to less than 0.5 ml per kg per hour for 6 hours, it's an acute kidney injury. The serum creatinine may still not look very abnormal. So that we need to keep in mind, because earlier the whole philosophy was to have elevated biochemical abnormalities or reduction in GFR to label a patient with acute renal failure. So that philosophy is changing quite fast. The other area in which people are trying to find out is biomarkers, which can pick up acute kidney injury at an early stage, even before you can find out the biochemical derangement of loss of GFR. And one of them is the neutrophil gelatinase associated lipocalin, the NGAL, as a real-time indicator of acute kidney injury. This is identified NGAL in the neutrophil, and it's a protein product which can be easily detected in the urine of animal models with acute kidney injury. And then they went ahead in the actual patients with acute renal failure. So as concept-wise, what you pick up by rise in the NGAL is actually the renal tissue which is actively undergoing damage, in contrast to rise in the serum creatinine, which is telling you the renal tissue which is gone. And this is the forest fire theory, where the red is the tree, are the trees which are on fire. And this is denoted by indicated by the rise in NGAL, and the trees which are gray are the ones which are burned down, which you will pick up by the rise in serum creatinine. So this is just in the background that how the whole thinking is going in terms of acute kidney injury. Classically, when you look at patients who have septic shock and have acute kidney injury, so these are criteria for initiating dialysis which are undisputed. So I would not go into the details like pulmonary edema, acidosis, hyperkalemia, encephalopathy, and at times the biochemical derangement. And there are two types of therapies which are used. One is the classical hemodialysis, and the other is hemodiafiltration. Essentially, the two therapies differ in relation to dialysis or hemodialysis being much more a diffusion based therapy, and hemodiafiltration is more of a convection based therapy. And diffusive clearance is based on the concentration gradient against a semi-permeable membrane, while the hemodiafiltration, which is a part of continuous, is a type of continuous renal replacement therapy, is more based on the convective clearance, where across the membrane, if you have pressure difference, water and molecules would move. And the important thing to remember in the convective clearance is the membrane used has a larger pore size. You have clearance of molecules which are of bigger size as well, and the convective clearance does not taper off, while the diffusive clearance would taper off with time. So these are the two important differences between the continuous renal replacement therapies and the diffusion-based hemodialysis. This slide shows you the different types of dialysis techniques which are used in acute renal failure or acute kidney injury. The intermittent hemodialysis we all know. The other technique is sustained low efficiency dialysis, where the flow of dialysate is also, the rate of flow is also reduced very significantly. Then there are types of convective therapies, the CRRTs, the continuous renal replacement therapy, which could be veno-venous ultrafiltration or arteriovenous. It basically depends how the blood is being drawn out. If you are taking out from the artery into the filter and returning into the vein, it's arteriovenous. If you are going from the vein to vein, it's a veno-venous. So it is just trying to explain the whole process. And the continuous venous hemofiltration, which is the classical CRRT, can also be combined with dialysis. So you can have FHD, which is a veno-venous hemofiltration and hemodialysis, and the other is peritoneal dialysis. This is just a schematic diagram where the red is the entry of the blood into the filter, and the blue is the blood coming out, and the UF is the ultrafiltrate. Because of the pressure difference in the blood and the dialysate or the other compartment, the fluid comes out as an ultrafiltrate. This is one of the prototype of the machine, CRRT machine, and this is comparing the three major types of therapies: the intermittent hemodialysis, the continuous renal replacement therapy, and the peritoneal dialysis. Peritoneal dialysis we are not doing except in very small children. We are mainly doing the CRRT or the intermittent hemodialysis. CRRT, the major advantage is that it can be done even in patients who are hemodynamically unstable, and you can remove a lot of fluid. It's a slow therapy which can go on for 2 to 3 days as well. So you can have much more successful hyperalimentation because a lot of fluid can be removed. In the intensive care unit, this is one of the reports where they looked at the number of patients who were on intermittent hemodialysis or PD or on or CRRT. Majority are still on intermittent hemodialysis, though there was some trend in 2000 for increase in the CRRT rates. This is our dialysis unit, and this is a PD cycler, and this is another prototype of CRRT machines. These are very machines which are very useful because they don't need very aggressive monitoring, and patient can be hooked. These machines are portable. We actually wheel them into the intensive care unit, which happens to be on the same floor as our dialysis unit, and also to sometimes to other wards, and even the medical ICU as well. So that way they are very convenient. The acute kidney injury in a septic shock patient is a very grave situation, because these patients would have multi-organ failure, and with sepsis and volume overload and profound acidosis and hypercatabolism, these patients really are very difficult to manage. And besides the conventional indication for dialysis, which I mentioned about like acidosis and hyperkalemia and fluid overload, many of these patients we are giving CRRT even when biochemically they do not have these indications. So that is the concept of renal support, which I am going to explain as compared to the concept of renal replacement. The renal replacement essentially means that there is loss of renal function with biochemical derangement, and we are replacing it with dialysis. While renal support is a change in concept, which means besides replacing the kidney function or the biochemical derangements which have occurred, this serves an important purpose of supporting the patient and ameliorating the effects of various complications even from other organ failures besides the kidney failure. So that's, if you look at renal support, it supports the other organ derangements as well. It is more of an individualized requirement of a patient. So many times the decision is made more on clinical understanding rather than on biochemical derangement. Indications are much broader as compared to dialysis, and it is targeted for an overall support. Sometimes you might have creatinine of 1.2, 1.3, but you are just giving CRRT because the patient is very severely oliguric and you want to give hyperalimentation or a lot of IV lines are going on. So the examples could be volume overload without even oligoanuria or significant azotemia, and it's very useful for total parenteral nutrition, or if patient has severe resistant congestive heart failure, and also for fluid management in multi-organ failure. Then these renal support by CRRT, besides the CHF, resistant CHF, can also be used if these patients have hepatic derangement, some of the intoxications like lithium, and if they have severe lactic acidosis, which is not uncommon in septic shock, or electrolyte abnormalities and hyperthermia. This is a rough estimate of a patient with septic shock who may be on different types of fluid requirements, and in an intensive care setting, the total obligate input can range from as little as 3 liters to even 7 liters, and some of them may require much more. So the fluid removal requirement could be quite tremendous, and that can be done by CRRT. And essentially the definition how to differentiate a continuous therapy from intermittent therapy is based on the time. Any modality of therapy of extracorporeal blood purification which is lasting for less than 12 hours is an intermittent dialysis therapy. If it is more than 24 hours, then it falls in the category of continuous renal replacement therapy. I'm not going to go into the technical aspects, but would like to emphasize that continuous renal therapies, the diffusive clearances are much less as compared to the intermittent dialysis, where the clearances could be 150, 200 ml per minute of blood. But in the CRRT, the clearances are just 20 ml per minute. But the important thing is, because of the pressure difference and convection, you can remove much more of fluid in a convective type of continuous renal replacement therapy. This is a circuit showing how the blood from the patient goes through the filter, and by the negative pressure, one is removing the filtrate and replacing it by a replacement solution. So that is essentially a type of hemodiafiltration. These are some of the modifications of CRRT which can be, you can combine it with dialysis, you can combine it with even plasma filtration and adsorption system. And I mentioned SLED, which is a slow, low efficiency dialysis. At present, there is a lot of emphasis. Actually, people are now going more for SLED type of therapy, which is a slow dialysis, much more diffusive clearance occurs as compared to CRRT. And patients who have liver derangement, then this is molecular adsorption recirculating system, MARS, has also been used. At our center, we are very actively doing CRRT. This is a CRRT kit, and this is one prototype which we have been using for last over 10 years. And this is a group of about 120 patients where we had seen our experience of CRRT, and essentially in terms of the outcome, what it was coming out is the number of organ involvement, which was an important cause of mortality. And in these patients with septic shock and with multi-organ failure, the mortality which we found was around 70%. Lastly, I am just going to give you some of the present thinking of using CRRT and intensive support in critical patients with acute kidney injury. And this is one report where they tried to see that if you give much more intensive type of continuous renal replacement therapy, would it really benefit these patients? This was published in the New England Journal of Medicine, and the conclusion was that intensive renal support in these critically ill patients really did not improve the outcome as compared to the conventional CRRT. So essentially they are trying to say that one can really get away with the CRRT where you're removing fluid at the range of 35 ml per kg per hour. This is the conventional, and the previous study was looking at higher volume removal rates. And this is another study which has been going on trying to see in hemofiltration a much higher volume removal, whether it would really make any difference, and we are waiting for the final outcome. This was another report where they tried to see that if you do a continuous therapy at a very early stage in these patients who are having septic shock, would it really make any difference? The study has not really shown that it improves the outcome. At present, we do not know what is the best time to start the renal support in these patients, and most of the decisions are based, besides biochemical derangement, on the clinical outcome. These are the two studies, the BEST study and another meta-analysis published in American Journal of Kidney Diseases, where they tried to look at a very early institution of continuous renal replacement therapy, but unfortunately it did not reveal any significant benefit. And now they are looking at that in these patients who are very sick and having in the intensive care, whether you can add on, besides a continuous renal replacement therapy, a system of renal tubule cell therapy, because they are trying to look at that besides removing the biochemical derangement, there are other abnormalities which is as a result of the kidney injury, which can be replaced only by these tubules, tubular cells which are grown in a filter. So you are combining that RAD, which is a renal tubular cell grown in filter, along with the continuous renal replacement therapy. And this study initially was in experimental animals, and now we have a report even in human situation where in this report the survival was better in the group of patients who have the renal tubular filter along with CRRT as compared to the CRRT alone. In our experience, patients with septic shock who are really requiring continuous renal replacement therapy, the important factors predicting mortality, number of failing organs, need for ventilatory support, and if they do not recover renal function. Survival is not related to the degree of renal failure at presentation. And to conclude, what is the best dialytic modality? I would like to say that there is no superiority of one modality over other. An individualized approach should be used for each patient to optimize their management. Best modality would be the modality with which you are well versed and with the infrastructure which is available to you. These are some of the guidelines which you can look at. The Surviving Sepsis Campaign, which is the website is there, which was also published in the Critical Care Medicine. And essentially what it shows that there is level 2 evidence which shows that intermittent hemodialysis and the continuous therapies, if at all, are equivalent in terms of their efficacy. The advantage is that the continuous therapies they offer an easier management in patients who are hemodynamically unstable. I'm not a pediatrician, so we don't have much experience with very small children, but we have some pediatric patients who come and need continuous therapy. But this is one guideline published in the Critical Care Medicine, where it's a level 2 evidence of using extracorporeal membrane oxygenation, which has improved survival in even newborn patients with sepsis to the extent of 80%, which is really very remarkable. And the indication they have mentioned is having refractory septic shock or with the PaO2 less than 40. And they also recommended combining continuous therapy with the ECMO as well. So I think I will conclude now. Thank you very much.